Limb lengthening surgery is really part of what I call more limb equalization surgery. So it's one of a number of methods I use when a child comes to me, either through an inborn difference in limb length, or sometimes a difference that has occurred later on through growth, through trauma or other difficulties with the growing area of their bones. There's a number of techniques I have to equalize limb lengths, and they may be simple methods such as the shoe raise, or something referred to as an epiphysiodesis, where we slow one of the growth plates in the leg to try and allow the shorter leg to catch up with the longer one. Sometimes if the difference is larger, or if it's associated with a deformity, we might need more complex methods to try to equalize these limb lengths. And for that, we can try lengthening or limb reconstruction methods. Now, there's a number of ways that we can do that. Most of the time, it involves breaking the bone, then over a period of time with a specific rate and rhythm, gradually pulling apart the area of bone where I've divided it. And now we have to hold this in a particular way. And the most common way for me to do this is with an external fixator. These are devices where the bone is held with a combination of pins and wires that go into the bone, and there's often a ring around the leg when using the Lizaroff type fixator or talar spatial frame, and occasionally a bar down the side of the leg, and that allows us to control the position. And as well as lengthening, I can realign, so I can correct multiple areas if there is a deformity present too. There are more modern methods of limb lengthening where we have a rod that goes fully inside the bone, or internal methods such as lengthening nails. These can be used in some children, but because the growing areas of the bone are still present, I'm not able to use this in all children. It tends to be more for the older child who's almost finishing growth that I can consider these alternative methods. But they are quite a useful option that's available, particularly as they have less that you can see externally. Reasons for undergoing the procedure, it's maybe an inborn reason why one leg has not grown as long as the other, such as a congenital cause. There may be other acquired causes, which can be due to trauma, infection around the growth plate, or other causes why growing areas of the bone perhaps don't grow as quickly or in a bent or shortened manner, essentially. And it's these reasons why we use methods to correct the limb differences. So there are different methods that I can use for limb lengthening. The most frequent method I use is that of the talar spatial frame. This is an external fixator, so a device that sits outside the leg, where you have rings that go around the leg, which are fixed to the bone in a combination of pins and screws, and divide the bone during the operation. And we wait for a period of time for the bone to start healing. That's usually around 6 days or so. And then write a computer program that tells us how to adjust the fixator. And with that, we can correct length and alignment. So there may be a problem with rotation or angulation that I have to correct as well. And I can use this device to correct it with 6 degrees of freedom to quite a high degree of accuracy. Generally, the speed at which I lengthen is around 1 millimetre per day. So if we're to be looking at 3 centimetres, that would take around 30 days. But sometimes we have to go a little slower, depending if the soft tissues need a little longer to allow stretching out. Whilst it's this sounds like a long period of time, you're only actually in the hospital for the first 4 or 5 days, and you come to see me every couple of weeks during the process, and we regularly monitor with x-rays and clinical examination to check that we're getting to where we need to go. And while we're lengthening, we need to monitor to make sure that things are progressing well with movement of the joints. You're likely to need a physiotherapist all the way through this process to help guide you with exercises to keep the joint above and below the lengthening segment moving. When we've finished the lengthening period and we've got to the correct position, we then need to wait for the new bone that we've created to get stronger. And that can be a variable amount of time depending on the reasons why why we've had to go through the lengthening. Some areas of bone make bone more quickly than others, but generally it's we're looking at least twice the length of period again that we're going to have to wait. Sometimes it's a little bit longer. During this period, you'll be continuing with physiotherapy, and actually putting weight through the lengthening limb is usually encouraged. When it's strong enough, then we guide that partly by clinical appearance and partly by x-rays. Then we're returning to theatre to remove the frame, and often using a plaster cast for a short period once the frame has come off. Sometimes if the bone is strong enough, it doesn't even need a plaster cast. And then after that, we monitor things as things remodel to have a gradual stepwise return to activities as bone gets stronger. But limb lengthening surgery is a complex surgery and does come with certain risks that we have to consider. And it's important to understand these beforehand, not only to know what you're getting into, but also so that if there are any problems, the patient and the family can identify them early to try to help us deal with them more rapidly. The difference of the limb lengthening is that, unlike most surgical procedures where the surgery has finished when you leave theatre, for this one, it's essentially the procedure is continuing for some weeks as we're adjusting the fixator. So we do still need to keep a close eye on things. Now, we've got to consider what are the risks when we're in theatre. Now, when we're fixing the fixator to the bone or dividing the bone, there's risks out to the nerves, blood vessels and tendons around this area. And it's important we consider the position of this to minimise these risks, particularly where the deformities or differences in the leg are complex. Sometimes structures can be sitting in places that we don't expect, so there can occasionally be higher risks than usual. I'll explain that to you as we went through. We need to take care of, after the operation, to keep an eye on swelling, make sure there's not excessive swelling afterwards. And very rarely there can be a condition called compartment syndrome. There's too much swelling in the jacket that lies around the muscles that needs to be released. This is rare, but something important to consider. The bone that we're creating, we need new bone to form. Sometimes bone doesn't form quickly enough, slowly. Sometimes it can form too quickly and the bone can want to heal together before we've pulled apart, that early consolidation. That's one reason why we need to watch things together with regular monitoring to make sure that we identify this beforehand. When I run the program that we write together, I base it on a series of measurements that we make from specialised x-rays. And these x-rays we have to monitor as we go. Sometimes when we get to the end of the program, we need to fine tune to get the alignment absolutely perfect. And occasionally this can require other adjustments, but this is something we go through with the family at each stage. Infection is another important thing to consider. When there are pins going through the skin into the bone, there is always a risk of infection introducing from the skin, much as if you had a piercing. So for that, we teach you how to care for the pin sites and clean them regularly, and teach you how to identify the signs of a pin site infection. If this occurs, often it's antibiotics that are all that's required to settle it down. Sometimes, if it's not enough, it can require an adjustment to the fixation we use in the frame. But for that reason, we'll always be in close contact if there are any signs of infection. We then have to think about later risks. For example, when we take the frame off, there's always risks of the new bone bending or fracturing later on, which is why we have to take care and carefully allow you to return to activities. And again, that's something that we have to guide you through step by step. The final risk we have to consider with any surgery such as this is a risk of blood clots in legs or lungs. Now, the risks of this do partly depend on the age of the child. Younger children, it is vanishingly small, but as we get into adolescence and older, then sometimes we have to consider this risk as to whether or not we need to have any intervention to try to reduce the risk of blood clots by any medications around the time of surgery or otherwise. So these are the main things that we need to consider. Depending on the condition I'm treating you for, there may be other specific risks that we need to talk about, and I try to tailor the risks we discuss to the child in particular. But this would be something we'd need to discuss further in clinic. So the recovery process after limb-lengthening surgery, we need to break into several segments. The first thing is the immediate post-operative recovery. When you're on the ward, we give good painkillers to try to control initial pain. Sometimes there's a patient-controlled analgesia, so a button that you can press for pain. We work with a physiotherapist to get you up and moving, and ideally putting some weight through the leg if we're using a frame. When the patient is mobile, safe, moving around, and the pain is controlled, and we've taught you how to care for your pin sites and how to make your adjustments with the frame, then you'll be free to go back to your own home. This is generally around day 4, but that can be somewhere between day 3 and 5 on average. Whilst at home, you'll be continuing with physiotherapy as an outpatient. The importance of this is working with exercises to maintain the range of the joint above and below in the leg. When we're lengthening, we're not just stretching the bone, we're stretching the muscle and the tendons, as well as the nerves and the blood vessels. And these do grow new tissues as they go, but it can lead to tightness of the joint. So we need to make sure we don't lead to any stiffness that can be fixed. And this is very important during the lengthening phase. If we get to the end of lengthening, we've maintained that range of motion, then we can be a little calmer after that. The following lengthening phase is the consolidation phase, when we're waiting for the bone to heal. During this process, I'm encouraging the patient to put more weight through the leg and to continue finding that balance. We want some weight to go through. If you do too much, then there can be discomfort from when a fixation irritates the skin. But working with a physiotherapist is often very good to help try to negotiate that route. And then hopefully by the time the bone is well healed and we're ready to take the fixator off, we've got a patient who's able to put their full weight through it and is quite comfortable. When the fixator is removed, occasionally I use a plaster cast if necessary, but always something that can have weight put through it. But we'll be, again, getting you to put more weight through the leg and trying to strengthen up the new bone that's been grown. We'll then have a gradual process of return to activities. Usually it's about 3 months or so before doing impact activities, and on average around 9 to 12 months before doing full contact sports after this type of procedure. So other things that we can consider to promote healing, so I generally recommend most patients take a supplement containing vitamin B. In the UK, particularly in the winter months, many of us are short of vitamin D, and taking a simple over-the-counter supplement certainly helps support normal bone healing. Of course, avoiding anything to slow bone healing, such as smoking, is important. Generally, you have to avoid medicines such as ibuprofen or naproxen. These referred to as non-steroidal anti-inflammatory drugs. They can slow bone healing. So these are important to consider. But the most important thing to stimulate the bone healing is the physiological use of the limb. So putting some weight through the leg is the most important thing to stimulate that bone to heal up more quickly.